Thank you very much for the opportunity to participate in this fantastic meeting. Good morning, everybody. I am Fabien Praz from Bern University Hospital, intervention cardiologist, and I have received the not so easy task to summarize the treatment of the mitral and tricuspid valve within 15 minutes. That's not easy, obviously, and I will need to limit myself on some etiology of mitral and tricuspid regurgitation, but also some specific therapy I just would like to show you, and I will also focus on transcatheter therapy in order to show you which devices are approved in Europe and in the US, and which opportunity we have to treat patients at high risk. I just would like to emphasize that mitral and tricuspid regurgitation are very frequent disease, much more frequent actually than the one we treat the most, aortic stenosis. You can see that mitral regurgitation is about 3 times more often than aortic stenosis, and about half of these patients also have tricuspid regurgitation, a very often disease as well that we start more and more to understand. And what we can foresee for the future is that this disease will continue to increase because of the aging of the population, but also because heart failure patients tend to live longer due to optimized medical treatment and better prognosis in patients with heart failure. Nevertheless, mitral and tricuspid disease are still undertreated, underdiagnosed. We need to do more to diagnose this patient and to treat this patient. You see that patient with primary mitral regurgitation, meaning that with the pathology of the mitral valve itself, are only treated in about 1/3 of the patient, and these are data that have been collected after the introduction of transcatheter treatment. It's even less in the patient with secondary mitral regurgitation, meaning the patient with dilated left ventricle or left atrium that lead to a coarctation defect of the mitral valve. And finally, you see that patients with tricuspid regurgitation and right ventricular disease are extremely undertreated, but also that we don't understand this disease enough. The goal of transcatheter treatment has been from the very beginning. There have been actually a lot of progresses, as you can see, during the year. The goal has been to treat patients that have no surgical option, or patients who are high risk for surgery and that were actually refused for open heart surgery and therefore did not receive any treatment. It's not a competition with surgery, much less than it is the case for TAVI, but it's really about treating patients that have no option in the best possible way and also according to their anatomy. We are also supporting data, and I just show you one of the randomized trials, a very important one that's focused on patients with heart failure and secondary mitral regurgitation. And you can see that edge-to-edge repair over a follow-up of about 5 years was able to reduce mortality and rehospitalization in this patient, and that this could even be reproduced in crossover patients, because patients could receive edge-to-edge repair 2 years after the beginning of the study. Patient from the control group, you see that even after 2 years, these patients were able to benefit from a reduction of death and rehospitalization for heart failure. So a very effective therapy in patients with heart failure and in combination to guideline-directed medical treatment. It's a success story. I think that's what you can see here with an increasing success of the procedure to reduce mitral regurgitation, and this is due to better selection of patients, to better team training, not only the interventionalists, but also imaging specialists to select and guide the procedure, and finally also, of course, to the improvement we had in terms of technology, and this had immediate consequences on the mortality with a reduction of mortality. You can see a very large registry also coming up and being published here. The American registry is showing the effect of edge-to-edge repair, mainly with a mitral clip in patients with primary mitral regurgitation. And you can see that we need to achieve a very good result, meaning no more than 5 millimeters of mercury of gradient, less than 2+, 1+, or 0 in terms of mitral regurgitation reduction. And finally, we need to be safe as well. And you can see that these procedures are actually extremely safe, with 1.1% hospital deaths 0.0 stroke and 0.6 access bleeding, so extremely safe procedure. Are we able to be safe and effective in all patients? That's probably not the case, and we need to select patients appropriately based on anatomy. You have an example here, a quite young patient refusing surgery. This patient has been seen and discussed with surgeon, and you can see that this patient has a classical play leaflet of the posterior part of the center of the mitral valve without other comorbidity. And in that patient, because it was the preference of the informed patient, we perform a mitral clip in a classical anatomy, and you can see that we were able to achieve with the implantation of XTW clip, which is the largest one, that we were able to achieve an excellent result that will also most likely be durable in this patient, fast recovery, and a good alternative to surgery. There are, of course, patients who are much more complex in terms of anatomy. The one I just showed is a classical one that would have been included into the very early Everest 2 trial, but we have to deal with a lot of other kind of anatomy calcification, short leaflet, patient in whom we sometimes cannot achieve a perfect result, and this patient have a less good prognosis. Now, we can see also that the effectivity of the clip or Pascal device in this patient is less, and this has also an impact on their prognosis. So what do we do in this patient? So again, we need to select them, we need to detect the anatomical complexity. And in the patient in the third category, we need to seek for alternative option, in particular replacing the mitral valve. That's not different from surgery. Surgeons do the same. If they are not able to repair the valve, they will replace it, and this can also be anticipated before the procedure. One of the options is a transapical option. That's a surgical procedure, transcatheter. The valve is delivered through the apex of the left ventricle and is then maintained in position with a tether or a cable that is fixed at the apex of the left ventricle. This is therapy that is approved in Europe and very effective to treat patients with complex anatomy for edge-to-edge. You can see in that particular case, calcification, a low mitral valve area in a patient that you will probably not be able to treat with an additional clip. Closing this valve, as you can see here, and the 10-line procedure introduced through a 36 French device through the apex of the left ventricle is a very effective procedure for this kind of patient with complex anatomy. They need to be suitable for this for opening of the chest. So this patient need to have some reserve to be able to be treated on this way, but this is possible with very good results. So the valve is introduced here on the upper images, introduced at the tip of the catheter, and then finally implanted in the right position. Obviously, one of the complications you can anticipate here is the LVOT obstruction, and this needs to be looked at in a very careful way on CT images before the procedure. When the valve is in place, then you will place this pad on the apex of the left ventricle. The tether is still accessible in case of retentioning, and finally the chest is closed and the patient can go to recovery. The future, how does the future look like for patients with complex anatomy for edge-to-edge repair? Probably like this, with the implantation of a transcatheter valve, not through the apex of the heart, but rather through transfemoral transeptal access, like the Intrepid valve from the company Medtronic. You can see that this valve is still perfectible. It's not a perfect therapy in terms of size of the catheter and also steerability of the device, but at the end function at a very good function when implanted in the mitral position, and is a minimal invasive procedure because it does not need any surgical access. The same applies for the Sapien M3 system that will get seen very soon in the beginning of 2025, where the principle of the procedure consists of implanting a docking station first in the mitral position, and then from the transeptal access, a Sapien 3 similar valve. You can see the access of the left atrium. The valve is completely coated in order to avoid and minimize the risk of PVL, but the function is exactly the same: rapid pacing, implantation of the balloon expandable valve into the docking station that has been placed up front, and finally retrieval of the catheter with a functioning valve that also has the advantage to catch the anterior leaflet and avoid the risk of LVOT obstruction. That's how it looks like on fluoroscopy. In implantation done in Toronto by Neil Pham, you see that the docking station is first placed, and as a second step, a transseptal Sapien 3 M3 implantation is performed with at the end an excellent result without any PVL of this valve in mitral position. So that's how the future will look like in terms of treatment of patients with complex anatomy. Of course, there will still be a very important role for edge-to-edge repair in all other patients where the anatomy is suitable and excellent result can be achieved. I would like to continue with tricuspid regurgitation in the time that is left, just by mentioning that tricuspid regurgitation is a very complex disease with different presentation, different symptoms, and as a consequence, we need for the treatment of this disease different type of transcatheter options, similarly to the surgeon who are doing different procedure in order to be able to treat tricuspid regurgitation. So we need edge-to-edge repair, we need annuloplasty device, we will need also replacement devices that are already approved in Europe and in the US. The first device that has been approved is an edge-to-edge, very similar to the mitral clip for the tricuspid valve, the TriClip device that allows to treat patients with tricuspid jet, mainly situated in the anteroseptal commissure. And this patient were after the implantation of two XTW clip, we were able to reach an excellent result with mild tricuspid regurgitation. That's a therapy that has already randomized data. You can see that in the TRILUMINATE trial, patients were randomized to medical therapy or TriClip treatment. There was no difference at 1 year in terms of mortality or tricuspid valve surgery, as well as in terms of heart failure hospitalization. But there was a big improvement in the quality of life of the patient that was directly dependent on the effectivity to reduce tricuspid regurgitation. So very important point, improvements of quality of life that is reproducible and sustained during 12 months, but depend on the efficacy to reduce tricuspid regurgitation. That certainly needs to be improved using edge-to-edge device. Another device enables a complete reduction of tricuspid regurgitation by replacing the tricuspid valve, also approved in the USA and Europe, the EVOQUE valve, with a very stable catheter from the transfemoral access, grasping the subvalvular apparatus and the leaflet of the tricuspid valve, and finally implanted as a self-expanding valve into the existing annulus. A very effective replacement of the tricuspid valve that, similarly to edge-to-edge repair, was able to improve the quality of life in a substantial way of this patient without other therapy that are no candidate for surgery, and finally also to improve their functional capacity as measured with the 6-minute walking distance. This is an example of a patient, very fast implantation in this particular patient with severe tricuspid regurgitation. You can see that the imaging is, of course, like for any tricuspid procedure, key, but that this implantation could be achieved in less than 20 minutes in this patient with severe tricuspid regurgitation. The future, we need to decide, or we need to select the appropriate patient for transcatheter valve repair or replacement of the tricuspid valve. And you can see some of the challenges that are very important when replacing the valve, with more complication, more bleeding, risk of new pacemaker implantation that is relevant, and finally risk of valve thrombosis. All these risks are not present when using edge-to-edge repair, but the price to pay is a less effective reduction of tricuspid regurgitation. Here my final slide comparing the transcatheter evolution of aortic and mitral and tricuspid valve treatment. For the aortic valve, a standardized procedure, very effective with extremely good supporting evidence, while the treatment of transcatheter mitral and tricuspid valve still require a lot of creativity and still require a lot of supporting evidence and studies to be done, which make it particularly interesting. My conclusion here, atrioventricular valve disease is undertreated, underdiagnosed, and need to be understood better. There have been impressive technological improvement, but also improvement in terms of outcome during the recent year. Repair and replacement are complementary technique. That's very important for mitral valve, and this will develop quite fast, I think, during the next years, while there is still a lot to learn regarding the timing of tricuspid valve intervention, and this definitely requires further research. Thank you very much for your attention, and enjoy the meeting in Seoul.
Thank you.